I don't think people appreciate that the biggest issue with us as medical providers seeing individuals remotely is billing. Like, I'm not allowed to bill across state lines.
But when the cancer came back, and my local oncologist, he knew it was too much for him. He needed help. That's when I got sent to Duke, which is a 5.5-hour drive each way.
There was a study that just came out in, I believe, JAMA Oncology, where for lung cancer, which is the field I work in, nearly half of individuals who are diagnosed with metastatic lung cancer don't get treatment at all. And for us, that's a shocking, but coming from Vermont, where I grew up, not terribly surprising statistic. Welcome to Cracking Cancer, where we tackle the tough questions about cancer with real patients and world experts. Our mission is to empower the cancer community through education, bring transparency to the oncology system, and drive funding for critical cancer research. Whether you're facing a diagnosis, supporting a loved one, or simply here to learn, we're here to bring clarity, hope, and action to the fight against cancer. Hey everyone, welcome to Cracking Cancer. I am your host, Dr. Kyle Concannon. I am joined today with JJ Singleton and Zach Schroeder, and we're talking about oncology care in rural medicine.
I'm JJ Singleton, co-host for Cracking Cancer. Honored to be here and can't wait for this conversation.
And my name's Zach. I'm a first-year intern at Wake Forest in Winston-Salem, North Carolina. I'm also a founder of the Rural Cancer Institute, we do a lot of research in just the rural cancer space. And so really excited to be able to join this conversation today to highlight a issue that is really close to my heart. So thank you all for having me.
Yeah, and thank you both for being here. And Zach, you had a melanoma yourself, and JJ, well known for your history with colon cancer. So excited to hear both your perspectives about navigating those cancers really in rural settings and the limitations they're in. JJ, we've heard from you, but Zach, maybe we can start with your perspective here about what your background was with that melanoma diagnosis and what drove you to really working in rural cancer advocacy.
I'm originally from a small town in southeast Kansas, population about 8,500 on a good day. And in about 2015 or 16, my hometown hospital closed down. And it was at that time that I really saw the need for healthcare in a rural community. And so since then, I've always been passionate about medicine, but not specifically oncology. Then going into college, I was pre-med at the University of Kansas. And at that time, on my 21st birthday, actually June 4th, I was diagnosed with stage 3 melanoma. And at that time, I was actually in Gulf Shores, Alabama, moved back home to my small town in southeast Kansas. I was able to travel to MD Anderson in Houston, Texas, a good bit over about 1,100 miles round trip to have surgery, radiation, and then followed up with immunotherapy as well. That I was able to do closer to home, but my surgery and my 5 rounds of radiation I did do at MD Anderson. And so it was through that experience that I became really interested or intrigued with oncology. And so then I started medical school about a year and a half after that with the passion for generally rural health and wanted to be a rural primary care physician. It was at the Rural Health Conference or the National Rural Health Conference in Albuquerque, New Mexico, where I heard about rural oncology for the first time and was able to reach out to the speaker and really got connected. And that's where I found my love for rural oncology. It was my personal experience with both oncology or my cancer diagnosis and rural health, pairing those two together that we started the Rural Cancer Institute. And that's kind of the origin story for the Rural Cancer Institute.
Wow. No, it's a crazy background, and I'm happy you made your way through it. Melanoma treatment went okay?
Yeah. So I started off, it was located on my neck. I never actually saw the initial lesion or the mole. And so after it was biopsied in Bartlesville, Oklahoma, I got the phone call when I was at work at Banana Republic. And the PA told me, hey, you have melanoma. We're going to send you to MD Anderson. And that was pretty much the end of the phone call. And at that time, I wasn't really in tune with medicine. And so at that time, if you looked up what is melanoma, I think it was Wikipedia said the worst type of skin cancer, and that was it. And so later on that day, anytime I would turn my neck, I would notice this large lymph node, which I didn't know was a lymph node at the time, popping out of my neck. And so I took a picture of it and sent it to an oncologist back in Kansas. And I was like, hey, like, I just got this diagnosis. This is what I'm seeing here. And he was like, okay, we've got to get you in sooner rather than later. And so it was kind of a birthday diagnosis date on June 4th, 2019. Went back home the next day to Kansas and had PET scans in Wichita. So that was about an hour and a half to 2 hours one direction to the nearest PET scanner. And then was told pretty much then that I was diagnosed with stage 3 melanoma and had metastasized to my lymph nodes. And the local oncologist in Wichita got my appointments at MD Anderson moved up. And so I had my surgical consultation on the 17th, saw a melanoma oncologist that day as well, and had surgery with a total neck dissection where they removed 50 lymph nodes, a fat pad, and the initial tumor as well. And then I had about a week to a week and a half recovery. I was able to spend some time down with my brother who was living in Houston in his house with his wife, and started radiation treatment, did about the first 2, but then flew back home to be closer to family. I did 5 rounds over about 2.5 weeks. And so for every single treatment, I would fly down to MD Anderson. Our nearest airport was about an hour and 15 to hour and 20 minutes away. So I would wake up about 2 or 3 in the morning to drive to catch the early flight to MD Anderson, get to George Bush, I think it is in Houston, and would catch a cab to the radiation center, get my radiation treatment done, and then get back in the cab and take it back to the airport, and then would fly home late in the evening. And so usually it was about an 18 to 22 hour day trip to get to treatment whenever I was doing the radiation treatment. Fortunately, there is a local infusion center in my small hometown, and so I was able to get some of my later immunotherapy treatments done there. It was me and some 75, 80-year-old gentlemen who we just sat and talked. And so I was one of the very few young people that have probably ever stepped foot into that rural infusion center. But thankful for that infusion center that was there. But I did this during my junior year of college. And so there was a lot of travel. Had the benefit that my parents were retired at the time and were able to take that time to drive me down to MD Anderson for those follow-up treatments, follow-up scans, things to that nature. But a very trying period of my life, but thankful for it in hindsight.
Yeah, I think you've done a great job illustrating just how logistically challenging getting good oncology care. And I'm a little biased. I trained at MD Anderson, so I think they do a pretty good job.
Yeah.
But to be able to access that is something that a lot of folks who are in urban settings, I wouldn't say they take for granted, but it's not always appreciated to us, even in the medical system, how logistically burdensome it is to get to us and what the alternatives are if you can't get to us. And I want to dive into that in a little bit here. But JJ, you also were diagnosed in a rural area. Was your access or your path to care similar and incredibly logistically challenging as well?
Yeah, I had a very different route because I stayed with the kind of local cancer center during my first diagnosis. It was in Asheville, so it takes me about 35 minutes to get to my cancer center from my house, about 45 minutes to get to the hospital. But when the cancer came back and my local oncologist, he knew it was too much for him, he needed help, that's when I got sent to Duke, which was a 5.5 hour drive each way. So that was the logistic part of that. And I was lucky enough to do all of my infusions still to this day in Asheville. But during that first part, especially when I was going for my clinical trial, I think I made 7 trips within a month down to Duke for the scans, for the workups, filling out the paper. And if I wouldn't have got put in the hospital, we were planning on doing my treatment every 21 days at Duke for the first 2 years. But I got put in the hospital, and my doctor worked something out with the drug company to get the drugs shipped up to the hospital and then to Asheville. But it was very complicated and a lot of travel.
No, that certainly sounds it. And you're describing 70 hours of travel in a month, in the car. And I think it's really challenging for people who are in a rural setting and they have access to something to know, is it worth it to do that? And I think that's something we struggle with in academic centers is we appreciate how logistically burdensome it is, how much time it takes to get over here. For us, we run trials here at the University of Colorado. Many academic institutions run trials, and we have to weigh, do we think it may be worth it? And we have to articulate that in a way that helps the patient make that judgment call. Is the logistical challenge worth the potential benefit for this trial? If we knew it was better than standard of care, there wouldn't be a trial. We would just use it. So that's something we struggle with at the academic centers too. But Zach, I want to ask, what do you think are the biggest challenges experienced by individuals in a rural setting who are going through cancer care?
Kind of what you were just saying. We did a study at this rural oncology practice in Staples, Minnesota, where trials are hard to come by, and they screened 200 consecutive patients for clinical trial, and there was one that was eligible. However, after I don't know how long they were on it, but they were eventually kicked off the trial because they didn't have dry ice in this local community to be able to send, I think it was a biopsy. And so, like you were saying, clinical trials are just really hard to come by in these rural settings. And with oncology treatment kind of evolving every single day, clinical trials, as we all know, are very important and kind of a backbone to treatment now. I think, don't quote me on these numbers, but I think it's 35% of cancer patients will travel greater than an hour to access treatment. And so when you think about just the sheer volume of people that are having to travel for treatment and the associated expense with that, a lot of these people are older and they might not be able to drive themselves because they're getting treatment that kind of precludes them from driving home. They just don't feel well enough to do that. And so maybe they're taking off time from work, but it also requires a family member to take time off of work a day, 2 days to be able to go and access this treatment. And these are individuals who already are statistically less insured or completely uninsured, and also lower income at baseline. And so the barriers are already there being from a rural community with a cancer diagnosis, and then they kind of just get added on top of one another. I think there was a study, don't quote me on this one either, I think it's like 24 or 25% of people will kind of change from a rural community will change their treatment plan or miss treatment plans just because of travel and cost barriers. And so if you think about like some cancers that have really burdensome, or not burdensome, but a high volume of radiation treatments, it's almost daily, every other day for an extended period of time. Mine was 5 over 2.5 weeks. There's some people that are doing almost straight 2.5 weeks worth of radiation treatment. And so if hospitals don't have the capacity to have those people stay at, a local hotel, low cost, even if it is low cost, that's cost to a patient that is normally not incurred by an urban individual, the barriers just keep adding up, and you can kind of go on and on for those. There's a study from, I think it was the Minnesota Claims Association that took the claims for different subspecialties across the state, and they found that people will travel further. I think it was a little over 75 miles to access oncology care. That is more than any other subspecialty, including ophthalmology. And so it just shows the travel burden that these people have. Oncology care, I don't know the most recent statistic, but like 2 years ago, oncology care was one of the most highly concentrated specialties across the country. And that, I think it was 10% of oncologists work in just 3 counties in the United States, and only between 3 and 5% will practice in a rural community. There was a study last year put out by ASCO asking who graduates from fellowship, and there was only one person that said they would be interested in a rural oncology or community oncology practice. And so I could go on and on about these studies, as a lot of these, JJ was there, just came up and were just published at the Rural Oncology Conference. And so there's just so many things that become significant barriers to care.
Well, and echoing that, there was a study that just came out in, I believe, JAMA Oncology, where for lung cancer, which is the field I work in, nearly half of individuals who are diagnosed with metastatic lung cancer don't get treatment at all. And for us, that's a shocking, but coming from Vermont, where I grew up, not terribly surprising statistic. I did my medical school and undergraduate at the University of Vermont, And being medically inclined, I was on the wards and everything, and shadowed an undergrad, and I was an orderly in undergrad, and then we like pushed patients around and stuff. And then doing med school there, I remember encountering patients who would come, they would travel to Burlington where we were, which was, an hour, hour and a half, up to 3 hours. And even that is really burdensome for individuals in these smaller communities. Like, to give some context, I grew up in southern Vermont, which was around an hour and a half, 2 hours from Burlington. And I had not been there until I stepped there for school. Like, it was just out of our sphere. So for individuals to go there at all and receive care, there's a cultural difference, I think, in a lot of rural settings. But even then, when we'd say, the best care that can be offered is down in Boston, it's a 2.5 hour drive, they would just say, no, not interested, not going to do it. So I think there's also a cultural element in the perceived barriers and what it's like navigating a big city if you're not from a big city, the fear associated with the traffic. Am I going to get parking? There's so much unknown that's not even the cancer, that I think it's a limitation for a lot of people. And I also wonder if you're in a rural setting and you're seeing people around you not get perhaps the best treatment that they could due to the barriers that you mentioned, they're seeing poorer outcomes around them. So their benchmark for what cancer looks like is different. How much of those elements do you think play a part?
Yeah, I think that's a really good perspective. And so something that we highlight at the Rural Cancer Institute is the rural cancer gap. The rural cancer gap is, if you look back to 2020 or 2000, and even before that, like into the 70s, there has been this gap in care. And prior to 2000, cancer outcomes in rural areas were actually better than those of urban areas. But as we've seen, like urbanization and kind of centralization of practice, this gap has switched. And up until, I think it was the ACS just came out with a paper talking about how the gap continues to widen. I have an image that I share whenever I give a talk that I think goes from 2001 to 2020. And shows this gap. And so mortality rates are declining across urban and rural settings. However, urban is improving at a much quicker rate than rural, and this gap is widening. And I think there's a study that said like lung cancer and late stage lung cancer accounts for like 40 to 45% of that gap. So that is a huge component of it, as you mentioned. But this is something that we highlight, and we like to say that there's more than just the travel when it comes to those barriers. Talked earlier about the costs to access care and these types of things that might just get overlooked because people in rural areas are diagnosed later, because it may be not just treatment, but it's also these like getting EGDs, mammograms. I think the closest mammography suite from my hometown was probably like 30 to 45 minutes. You can't get a colonoscopy done probably within 45 minutes as well. And so these things where people already have very tight schedules, these are easy things to pass up. Not to mention we only have, I think now there's one physician in my hometown of 8,500. And so there's multiple things that cause this. There's the lack of overall physicians in rural areas. There's the lack of screening in rural areas. There's the lack of health literacy in rural areas that lead to cancer diagnoses and being diagnosed later. And then you add on top of that, once they are diagnosed, there's barriers to access treatment, surgery, X, Y, and Z. And so all of these things just causing that gap that I talked about. In my fourth year of medical school, with the assistance from some individuals at the University of Kansas School of Medicine, I was able to get the cause of mortality across the country and was able to go state by state in what was causing the gaps. And so there's some states that have a very minimal gap, but then there's some states that have a really wide gap. And so recently I just gave a presentation in Kansas City, and I looked at Missouri and Kansas. In Kansas, the gap is actually relatively minimal, but Missouri, the gap is quite wide. Very similar states, and culturally, economically, and with like large academic centers. Missouri's, both of them are kind of trying to leave the state in St. Louis and Kansas City. And then in Kansas, you either go to Denver or you go to Kansas City. And so both of them have travel barriers. But there's something else that's going on that's causing the Missouri gap to be more wide than the Kansas one. And it's really hard to sometimes put, oh, this is the thing that works for this state. And so I then broke it down and then looked at different states and what might cause the worsening of gaps. And it usually just comes back to hospital closures in the state. And so Kansas, I know I said that had a relatively minimal gap compared to Missouri, but comparing it to other states, it has a larger gap. And Kansas is on track for about a hospital closure every 2 years in rural Kansas. And so that gap kind of infers that it might be screening that is leading to the worsening gap. But there's just so many players in the game that it's really hard to say, like, this is the one thing that's causing it. And at the Rural Cancer Institute, those are the things that we highlight and how do we minimize the barriers to care. So we have a publication in the New England Journal of Medicine, Catalyst, that talks about one of the models for care delivery, and it's called the Rural Oncology Home. And at this rural practice that I mentioned earlier in Staples, Minnesota, they have 3 oncologists there, all general oncologists, but about 25% of their practice will actually go to the Mayo Clinic to get a second opinion. And then in partnership with the Mayo Clinic physician, they get to do most, if not all of their care then closer to home. And so they get the high academic care that you would normally see in a rural setting, staying closer to home, mitigating the cost barriers. And then I could go on about like the finances of hospital closures in small towns and how I think there's a study that says it's like 25 to 40% on average. I think it's about 33% of hospital revenue, small or large, can be from their oncology practice when it comes to the ancillary services that come with that. And we often see that economic revenue for those small hospitals is just kind of bypassing, leading those to hospital closures. And so this small rural hospital is really thriving because of the oncology service that they have. They now have radiation, they have palliative care, they have all of these things because they have their oncology service line.
And it's funny, I think I'm not sure the public appreciates just how strong the discrepancy is. Like, let me give you an example. You know, when I was out of fellowship, people are approaching the end of fellowship. People are trying to recruit me. Like, oncology is a very lucrative role in all settings. Oncologists make money for a given academic center, and there's a big need for us. So even at a big academic center where we have plenty of oncologists, the wait times are still really long. Anyone who's experiencing oncology care can attest to this. The wait times are too long everywhere. But the amount of money I would make, which I'm kind of using as a surrogate for how needed I am in a given place, in a rural setting is 2 to 3 times what I make at an academic setting. And so I get these pamphlets all the time mailed to me. I mean, probably one a month that's come to this rural setting. You work barely none and you get all the money. And, you know, so they try to make it as lucrative as possible for an oncologist to move there and start seeing patients because they struggle to recruit so much. And it's interesting because you look at where some of these places is and, you know, where they are. And for me, coming from rural Vermont, if I wasn't a physician scientist, these places would be very appealing to me. But I can see how most people didn't grow up in the boonies. And, you know, they grew up in urban settings. This is the feeder programs to get into med school. You know, you came from a rural area. I came from a rural area. Getting into medical school was significantly harder, I think, for us than for individuals who have a lot more opportunities in urban settings, and they have all the resume padding and they have the tutoring and they have the extracurriculars and all this stuff. But if you're from, you know, my town with 7,000 people, there wasn't a whole lot going on for you to distinguish yourself. And I think I was certainly the only one my year to go into medicine from my high school. It's just it's pretty uncommon. So, and those are the individuals who are used to being in urban settings. So I think there is an issue, and I did my med school at the University of Vermont. And even then, most people who train at the University of Vermont still aren't staying in rural settings. We had more Californians in my high school than we had Vermonters. There's just not a whole lot of rural people. And there are a lot of Californians. Too much, I would say. I'm going to go ahead and say there are too many Californians. They're invading our medical school. That was really the purpose of this podcast. No, I'm joking to the people in California listening. Although they're pretty used to it. But no, it's I think it's a systemic challenge, and I also could speak all day to the barriers, and I can't say I'm contributing to the solution, having gone into academic medicine and now having a laboratory and a big academic center. I'm very limited. I can really only work at academic centers. But that being said, the care I provide here, most of it is cognitive. Like JJ, I'll put it to you. Do you think that the care that you received at Duke, and I'm gonna talk about the systemic long-term care. Do you think like the surgeries and radiation? A lot of times those are person specific. But for your medical oncology care, could all of that been done, do you think, by a Zoom call or a phone call? Or what value did the in-person interaction add for your care?
Yeah, I think the very first initial meeting is always in person, should have been, so I was totally fine there. But crazy thing is, after COVID, where we had to do everything on Zoom because they couldn't, so I haven't been back to Duke since COVID happened. I do all my twice-a-year meetings online. So before that, I was like, well, I wasted so much time driving down there for these, hour meetings, a scan that you can log into my portal because you have access because you're my doctor to read and look at because it gets sent right to you. And it just kind of like, why didn't we make this connection before when you were making me, waste 10 hours? And like my mom, because when I was really sick, I couldn't drive. I was on a pain pump. So my mom wasted about 12 years worth of days she had built up in the school system. She went from like almost 6 months worth of like paid time off to 0 days through my diagnosis and taking me places, staying at the hospital. So I don't think I could have got like the access to the trial or the information of that magnitude at my local cancer center. But the care that I received there is just as good. Like my oncologists, the nurses, the attention that they give me, I feel is adequate and just on the same level. It's just the access to that top tier information of like new breaking drugs, new treatments, new, anything new. It's going to take a while to get that 5 hours to the western part of North Carolina because there's no major, academic center. And y'all were talking about like the barriers for screening. Like Western North Carolina is about 13 to 15 counties, depending on where you like draw the line at, and right under 2 million people. And there's 7 people in the whole 14 counties that do colonoscopies. And that's it. And half of those people, you have to drive 2.5 hours to just do that. So like that, those barriers, yes, very big, but the care that I received at my cancer center is great. Just access to the new information is like the biggest thing in my experience.
Well, colon cancer is a great example because a colonoscopy is not a pleasant or easy experience. Like a mammogram is still painful, but not as bad as a colonoscopy. Chest screening is very easy, but people already don't want to do colonoscopies. Like that's pretty well known. So then you tack on, 4-hour round trip and how, the conscious sedation, like you're going to get home at midnight. It's just like very easy to pass on that.
I think that's a really good point. JJ's story just highlights so many of the barriers. And I think you highlighted the remote patient monitoring too. I think that's how JJ and I initially met, was at a PCORI event in Washington, D.C. And then I was invited back later to talk more about remote patient monitoring. And seeing that kind of evolve, I think will be huge for rural-based populations when it comes to cancer care and clinical trials and these kind of things. Because if we are able to monitor the patient closer through Zoom or whatever it might be, I think is a huge barrier that could be removed.
Oh, I couldn't agree more, and I don't think people appreciate that the biggest issue with us as medical providers seeing individuals remotely is billing. Like I'm not allowed to bill across state lines.
Yeah.
And that is insane. Like nothing magical happens when we cross the border, into Arizona or Wyoming. There's no dramatically different healthcare system that means my medical expertise is no longer valid. But but it all becomes a billing thing. So, which is legislative. That's really, I think, the biggest issue in providing access to individuals in rural settings, because most of my decision making is done by the chart as a medical oncologist. And then even I would say probably the surgeons, the radiologists, if they have the scans and they have the tools, a lot of what they need to know can be done by the chart and through a Zoom visit. Very little these days in oncology care truly hinges on the physical exam for decision making. It is necessary to make sure the person's well enough to do the thing you may want to do. And in cancer care, a lot of times they really aren't. But you can get a good sense of that from Zoom and the history. So really the element you're missing are vital signs, perhaps, and a formal physical exam, which could be done as needed. But I'll give an example of some of the barriers. And JJ, you were mentioning this. The pace of academic advancement is incredibly fast in oncology. The use of ctDNA testing, where we're drawing blood tests that will monitor and look for molecular changes. We're looking for DNA changes in the tumor. And then the treatments are changing too. So the way we're analyzing the tumor and the way we're reacting to what we analyze is changing in real time. And, I recently had a patient who was being treated in a rural element of the state of Colorado, very far from here, from Denver. And their provider, I would say, misinterpreted one of these blood tests that didn't see a mutation, and they were not as familiar with these blood tests as I am, because I use them every day, and I only treat lung cancer. So I'm very used to looking at these. And they didn't appreciate some of the limitations of that blood test in this specific circumstance. And they concluded the patient no longer had this mutation. They changed treatment, and the patient progressed in the brain, many brain metastases, when we had treatments that work really well in the brain for what they had. So that is a great example where a phone call with me, a Zoom call would have said, hey, wait a minute, you can't use this test this way. We actually need to do this test over here. And in the meantime, I recommend changing to this. And it would have it would have probably at least informed the patient of a different path. Who knows what the patient would have chosen, but there were alternatives there that, to the credit of the rural provider, it's just, there's so much going on. It's really impossible to keep up on every disease type, every new assay or test coming out. You really need access to people who have some sort of specialization in these nuanced circumstances. And Zach, I'd love to hear your thoughts on this, but the biggest frustration I feel is the tools are currently in place. The barriers are these invisible billing and bureaucratic barriers, meaning it's really hard to get these Zoom visits, and they can't always be billed.
That's really true. I think I didn't do any, maybe one during COVID, like JJ was saying, virtual visit, but every time I drove down, reflecting on it, every time I drove down to MD Anderson or even to Wichita, how many CT scanners did I drive past? I could have gone, 5 minutes down the road, and there's a little community access hospital that has a CT scanner in their emergency department. I could have gotten my scans there, and then, called on a Zoom like we're doing right now, all of us located across the country, and being able to have these conversations. That's another thing that, going back to your question again, that's another thing that we're doing at the Rural Cancer Institute, is really trying to build community around the rural oncologist. There's so few, and they're kind of few and far between too, and just spread across the country. And Dr. Swenson, who's located in Minnesota, at the time we asked 3 years ago, before he started doing a lot of his advocacy, he wasn't really aware of another rural oncologist really in the country. And so he was felt like he was out there by himself doing these things. And honestly, he kind of is, but more oncologists are actually going to rural areas depending on what state you're looking at. And so we're trying to build community around hey, what worked well for you in this scenario? How did you stay up to date? What are you doing, especially with AI and those kind of things coming out? What did you do differently in your practice to make sure that you were staying up to date and doing what's best for the patient in this scenario and this scenario? And so really trying to build that community to share ideas across platforms to do those things. And billing will always be a tremendous barrier. I'm not super versed with it right now, but it just kind of keeps getting extended out, I believe. And I think it's just like expires at the end of 2026 or 2027. There's nothing that's permanent. And unfortunately, it's a barrier to care, not just in oncology care, but in just across the board. Dr. Gary Doolittle out of the University of Kansas, he's a melanoma oncologist, and he was one of the first providers in oncology to do kind of remote patient monitoring, but telehealth as well. And so he spoke at our first Rural Oncology Conference and just gave really great perspective on how telehealth has come so far, but yet we still have so far to go with it to make sure that we can provide the best care using our phones. There was one, I don't remember who gave this perspective, but like you were talking about earlier, vitals being a huge thing. Maybe it's physical exam. So maybe it's, you go down to your local community access hospital that's 10 minutes down the road, and you have a room that's the subspecialist room, and there's a nurse that rooms you just like you would, and they take your vitals, you get on the Zoom through their computer, and then you talk with your subspecialist provider, if that's being a surgeon, whatever it might be, and they can say, hey, like, will you check the rash under Miss Vicky's right arm? And the nurse then helps them take a picture of it, because these people usually are older. They have Wi-Fi barriers. Like, I don't think I've ever lived like a day without Wi-Fi, but there's a lot of people out there that have connected issues. And so connectivity is a huge problem. And so if you could use the local hospital as the connection to connect people, I think that is a great option for billing and those kind of aspects, because you are getting a physical exam, you are getting vitals, you're kind of getting those things that are necessary for patient care, and you're still able to do it close to home.
Yeah, and that paradigm that you're just mentioning, where the requisite clinical stuff is happening locally, but your cognitive stuff, the decision making, can happen remotely. People have been working on that. One of the challenges, and I guess the site that the patient is at will bill an RN visit. They'll bill for the vitals, for the time. You have to have the equipment. I know there was a company that I saw at a conference that makes what are essentially hologram chairs. So you sit it's just like a regular chair in this box, and it creates a hologram of you, and it creates a hologram of the person across from you, which, in my world would be myself and a patient. And it just looks like we're sitting across from each other. And it's very crazy. I don't know if the juice will be worth the squeeze. But I think, time will tell, and those things always get cheaper over time. But, right now, the fact that we can't bill across states is a huge issue. So for someone who's in Wyoming listening right now, you sometimes will have reciprocity, but that's literally like an exception to the rule. So Denver might be able to bill to you. Actually, right now, I don't think we can, but Houston probably can't. So, is there something unique to each state's individual medicine that makes I have to be licensed in this state? And I don't think so. No, it's just the state that wants the licensure, and I don't know enough about the complex legalities behind it or why they're so exclusionary. But it's not like I'm going to go get my license in all these other states so I can do telehealth. It's not feasible to do that. And I don't even know. Yeah, I wouldn't even know how to do that. It's a huge pain to get your medical license in some of these states.
I bet that is a huge barrier for you all in Denver, because I'm not sure about the numbers in Wyoming, but Wyoming, I think, has like one of the fewest oncologists per capita. And so you guys are probably seeing a huge Wyoming population. And so like right there, you have a barrier to telehealth, which would be tremendously beneficial for these people to travel down, yeah, especially with the winters you all have, with snow and all those things. And so just one barrier after another. Well, and overcome one, there's one in the way.
The workaround is individuals can have a telephone visit with you, but they have to be in the state. Mm-hmm. So you have to cross the border, dial, and do that to be like legally billable. Mm-hmm. If you don't do that, then you risk for fraud. So yeah, it's just, and like, what is magical about it's just, mm-hmm, it's totally contrived. But one thing I wanna get into, and JJ, I'd love to start with you here, is the social isolation that you feel not being around a major academic center. Do you think that was unique to you in a more rural setting versus individuals who live, right in the area around Duke for you?
Yeah, I think that's like many factors of the isolation there because over my journey, I've learned that major academic centers and their cancer centers, they offer so much more mental health, so much more just access to other patients. I've still never seen nobody my age at my cancer center, even though I go to Asheville, which is the biggest city in Western North Carolina. Like 11 years, and there's been nobody my age that I've sat at or seen in the infusion center. So I think that's an aspect. And then just the isolation of almost being fearful of that because it is so different. Like you were saying earlier, a city, a huge, well-known cancer center. And I'm like, I'm this kid from Canton, North Carolina, who doesn't know how to say half the words that you're telling me in this there. So how am I even going to be took serious there when I don't understand that? Now I know that's, most patients, even if you live in a big or right next to the institute, most people, unless you went to school, you don't understand the words. And sometimes even then there's words that people don't understand in this. So I think just going through it has helped me, break a lot of that isolation and able to help others. But it was a lot of hurdles just in my mind and myself that I had to get over to go to somewhere like Duke.
No, I love how you brought up the cultural differences, really, so I grew up in a pretty low healthcare literacy family. My father had dropped out of high school. He had a GED, and my mom mostly stayed home with the kids. So we didn't have any healthcare background or higher education. And when my brother was sick in an ICU, I remember as a kid, in my maybe early teens, 10 to 13, around that time frame, I remember looking at the physicians who would walk around with a clear dialect like I have now. They're not using rural jargon, and they seemed so much more intelligent and naturally smarter. It just felt like a different class of human. And it was just so foreign to feel like I had the same, cognitive abilities that these people do. Like it just seemed totally foreign. And we didn't understand much of what they were saying. We felt it was really rude and stupid of us to question it. We were just so insecure and fearful that it was really just going along with whatever they said. And we, were a very religious family. So we would just pray for things, but we didn't have a lot of understanding of what was going on. And we felt like a burden on the well-trained, polished clinicians to ask questions and to dig in. And I don't know how to, one, Zach, I'd like to hear if that's a common sentiment from your perspective. And I don't know how to overcome that.
Yeah, I think JJ brings up a good point. Even both young when we were diagnosed with cancer, and so that immediately is isolating. And like JJ, when I was down at MD Anderson, there was these group of older ladies, and I was walking back to a CT scan, and one of them goes, "Oh, that boy's too young to have cancer." And so there's just so many elements to cancer care and cancer that, especially from a rural community, both of us being young, that was tremendously isolating. Dr. Doolittle, I mentioned him once already. I was giving a talk that he was at, and he came up to me and we spoke after. And he gave a reference to somebody that he was treating when he was really young in his career. And I don't know when, it was either wheat harvest or soybean harvest or something like that. I don't remember when it was, but he told the patient that he was like, "Hey, you're going to come to Kansas City. You're going to do these things on this date." And the patient was like, "I can't do that. That's harvest season." And she was like, "What? Like, what do you mean? Like, you're not going to come to get this like life-saving care at this place?" He's like, "No, I have my harvest. I have to do this." And so there's the cultural differences. And I think those stories, I think you kind of mentioned one earlier as well, are not few and far between. The differences in kind of what is expected is totally different. And I think the biggest barrier is that people or providers in these urban settings just expect people to make the drive or to make the travel and make it happen. and don't really take into account what impacts this is going to have on some people's life. Because in a rural community, a lot of people, the last thing they want to do is, hinder somebody else, ask somebody for a ride. Hey, can you take off time work to do this and this? It's a really hard thing for those kind of people to do. And so they would rather pass on X treatment or whatever it might be, because they don't want to impede on anybody else. And so I think that's one of the biggest things is the expectation from urban setters, like, hey, this person will do this because this is the best. It's not always the case.
Yeah, I think you're articulating well some of the unappreciated or misconceptions that individuals at the academic centers may have for their rural patients. What do you think are some misconceptions that patients from rural settings have about academic centers or cancer care in general?
Yeah, that's a really good question. I think it's multifaceted. And so these big academic centers, there's more people in the hospital than in some of these people's hometowns. And so they go to these places and they've never been somewhere so big. My dad is from a small town in southeast Kansas, and he had never really traveled outside of a 3-state area. He ended up, his first job was like in the Philippines, but he branched out. But a lot of these people have never left their hometown, and then they get this diagnosis. It's already big and scary. And then you add on this big and scary place that is an academic medical center. And I think one thing that we've done throughout this conversation, one thing that we do at the Rural Cancer Institute, and I fault myself for it, is we talk about the negatives of cancer. But I think JJ did a great job highlighting some of the positives. When he goes to Asheville, to his local cancer center, the people know him, the nurses know him, and he walks in and it's just, JJ's here, we know JJ, right? And I think that's one of the highlights of these rural cancer centers that are there, is that people know you outside of the hospital. They know what's important to you. They know your family. They know maybe where you live and just different aspects to your care that they might be able to appreciate. And so I think that's one of the highlights of rural cancer care and rural cancer delivery. Even though the outcomes and all of these things that we could just show data that there's barriers to care, yada, yada, yada. But I think this is one of the highlights, and that kind of circles back. I think that's what's really important to these rural patients, is that they want somebody to know them, because everywhere they've gone their whole life, somebody has known them.
What a great point, and I think one of the biggest challenges I hear for a lot of patients and through this podcast too, is the feeling of social isolation and kind of the feeling that you're doing this alone. And that's where some of the advocacy organizations do help. And I'd love to get into that a little bit, that element of your group. But also, that is a major difference that I can speak to my personal experience from growing up in a small town where everyone knows each other, and there is mutual support. And you have to rely on each other because it's rural settings. And, again, we were a pretty poor family. We relied on other people for a lot of things, and we reciprocated that. So this feeling that everyone's got each other's back. And when you go to a large academic center, I'm going to call it MD Anderson just because you went there and I trained there. The likelihood you get the same nurse is pretty low. Like when you go into infusion, and I forget how many, hundreds to thousands of infusions they're doing a day, like the likelihood you're going to recognize, you could go there for years and you might not get the same nurse. So that continuity and this feeling that getting wrapped in kind of a social blanket, that I think is a real difference. That is a real cost. So we talk about social isolation of being rural, in that you have fewer number of people around you, but the number of people that you have around you are closer to you. So you may actually be less isolated. That's a great point.
Whenever I was diagnosed with cancer, in the first 2 weeks I spent at MD Anderson, I would get like a stack of letters from people back home, just giving me letters of encouragement, support, prayers. And it was great. And I love those people for that. But like the biggest thing that I wanted at that time was to be at home in my own bed. Getting out of surgery and laying on your brother's couch to sleep, is thankful that I had that space. But again, like I just want to be at home. And I'm sure JJ has talked to this. He told the story about how he had traveled when he was feeling miserable, and a lot of those times you just want to be close to home with the people you love in the comfort of your own bed when you're facing the biggest uphill battle of your life.
Yeah. Yeah. And it's tough. I think there are things we can do in large medical centers to help make that achievable. And there's also the reality that the trial infrastructure is really hard to build out to rural settings. Um, but when you choose trials and when you don't, I think a lot of that comes in the cost benefit analysis. Um, so I'm curious to hear along that line, what do you think large academic centers can do to better reach the individuals in rural settings to provide them specialist level care in the context of their own home?
Yeah, that's a really good question. And I think it starts with the training because every single HEMONC fellowship is in a urban setting. I think it's like Lubbock is the one that's like maybe not Burlington with Dr. Barry is doing a great job at this, and they prioritize community oncology. The University of Kansas now has a rural oncology tract. Mayo has a community oncology tract, and there's more programs that are doing these things. But the thing that I hear the most whenever I say I want to be a rural oncologist is you can't do that. And so I think it's changing that narrative in large urban settings that whenever somebody's in their training that they can do this, and it's not something that is deemed a failure if you go into rural community practice, but a success. And so I think it starts with training those rural oncologists. But then once the oncologist is there, kind of reflecting back to your story and that oncologist, if they would have reached out, done this a little bit differently, that could have ended a little bit different. And so then it becomes a partnership and being able to access the subspecialist in urban settings while also having your community oncologist close to home as well. So I think it really starts with the training and kind of changing the narrative in these urban settings that rural or community oncology is something that you can do.
Do you think there are particular areas where, or let me rephrase that, I suppose, do you think there are particular websites or groups that individuals who are socially isolated or geographically isolated can go to for information and support?
Yeah, this has been something that's been brought up at the Rural Cancer Institute often. We just have so many avenues that we're going in and don't really have the capacity. But we've talked about having both a space for providers, which we're working on, and a space for patients as well to go and to kind of have a central location for what rural oncology as a patient looks like and what it looks like as a provider. I don't know of any specific things that are out right now that are really good to go to. I know Vermont actually has a like kind of rural oncology conference. It's actually coming up like June 2nd through 4th or 3rd. And so going to things like that or going to the Rural Oncology Conference, our next one's in Chapel Hill, North Carolina, and just being able to get those contacts because it's not just people from rural America that come to these conferences. It's people from, Mayo Clinic and all these different places that are also passionate about rural care because there are people out there that are from rural communities like yourself that practice at large academic centers, but are still passionate about this. And so making those connections outside of what is kind of the normal of just your local practice. And so I think that is a good place to start. And that's something that we can continue to work at the Rural Cancer Institute is to really build out that community and those resources.
One thing I've heard too is people can feel really hesitant to get second opinions.
Mm-hmm.
And for an individual who's in a rural setting, a second opinion doesn't necessarily mean that you're leaving your oncologist and you're going somewhere else and establishing there, and your oncologist locally isn't going to feel slighted that you've done that, or they shouldn't feel slighted. But it may help facilitate, more nuanced level of care for people who have things that are kind of rare, which a lot of people do. Or it gives you the comfort and validation of the things that you've done. And then you can just go home and you feel good about that path and everything. And then the oncologist has a touch point, a specialist that they might be able to ping if a question comes up, just to provide an additional level of resource. That's something we're seeing more and more. But I have heard the limitation that, well, I don't want to upset, or, I like my oncologist. And it's like, great, keep seeing that person. They're doing a great job. But, if you ever need trials, you can come see me, or, that's a conversation I have a lot with my patients. And if they have any questions, they can ping me. And I'm happy to talk about some nuanced level of detail, like the one I was describing earlier.
I think that's a great point. I think at these large centers, you have really large teams. And I think that's something that hasn't kind of percolated into rural communities is large teams because there's just a lack of providers.
Yeah.
And so rural patients aren't aware of these large teams that usually are taking care of a patient. And so even just on my internal medicine service, when we walk in as a whole team with pharmacy, meds, all these people are, especially from rural areas, are like, whoa, why is there so many people? And they're like, oh, you're all thinking about me. And so I think just like growing that team that's taking care of you, the subspecialist in the urban setting, but your local provider is huge. And it's really important in medicine. We just need to make it kind of the status quo in rural areas.
Yeah, I mean, when I leave a patient room and there's a complicated decision to make, I frequently talk to the provider next to me, or I'll, call one of my colleagues and say, hey, this is a little challenging. Here's what I'm thinking. What would you do? But I work with them. I know them. It's really easy for me to access them. So even just establishing somewhere gives that connection point that it's like, if your team is in a bit of a bind and complicated decision making happens all the time, this stuff, most of the decisions we make are not driven by trials. So it's helpful to have someone who's got a lot of experience that you can get a second thought on or bounce an idea off. We do that together all the time.
Yeah, very much so. Could not agree more. I think it's really important. Granted, I'm just an intern, but I love having support there. And I think rural providers love having support. And so I think it's really important to highlight that team-based care.
Yeah. I think so too. And JJ, starting with you, one question as we wrap up. What message would you want to send patients who are in rural settings or families listening to this today?
I would say just be open to the opportunity that if you're able to get to a major cancer center, do it. And there are resources out there like the Rural Cancer Institute, advocacy groups in your whatever cancer you have, and the community that they've built where there's other people across the country that are in rural areas that can be a connection to you, or that you can bounce ideas off of or talk about issues there. And you have that trust in them because they're going through it too, to where you're not alone. You're not in your small town, your rural area. And you could talk through that, use those connections to try to break the barriers and get the best help and care that you can. And just not to isolate, because it is so easy in a small town when you already feel like you're the only one in that town that has cancer. Everybody notices you or talks about you or asks you how you're doing and if you're doing okay every day, that there are other people out there and there are other resources that can help you get the best care that you can.
Well said, JJ. We didn't get into it, but the patient advocacy organizations, if you have a rare mutation or a rare disease, the odds are very high.
There's more groups growing like every year. Like just in my 5 years of advocacy, the amount just in like the colorectal cancer space, but then the AYA and the clinical trial space is like every year there's just more and more. So there's people out there that want to use their expertise to help people.
Yeah, and it's a huge, huge resource. I ping the patient advocacy organizations for my patients. If I have a challenging situation, I'll ask the leaders of those organizations, hey, do you have anyone who's been in this situation? What do you all think? Because they're the experts of having their disease. And you get all of them together and they collectively know pretty much everything there is to know about a very nuanced, detailed thing. So that also kind of serves as a second opinion for people who have also walked the walk. And Zach, any last sentiments for individuals who are listening here from rural settings or words of wisdom?
Yeah, I would just piggyback off of what JJ was saying. There's people that have melanoma, there's people that have colorectal cancer, and they might not be in the same, melanoma or colorectal cancer group. But when you're from a rural community, it's a totally different battle. So across all kinds of cancer, the issues and the barriers that you'll face are unique to you. But not just unique to you. There's people across the country that are from other rural communities that are facing the same barriers that you are. We have Rural Cancer Awareness Day coming up on June 4th. We have a rural cancer ribbon, just really acknowledging the barriers that rural cancer patients face. And so realize those, celebrate those, and then make connection over those, because some of the barriers you'll face are the biggest barriers you'll ever face in your life.
I love it. And, for those listening, particularly coming from rural areas, you can feel really alone because there may not be a lot of people around you who are walking the same path you have to walk. But there's a lot of people out here on the provider side, on the advocacy side, who want to walk with you. It may take a little bit of effort to find us, but hopefully, if you're listening to this podcast, you're putting that effort in, and that's how you listened. But there's a lot to be gained from making those connections, and I think that's a good place to end. So thank you both for joining us, JJ and Zach. And everyone else, if you have further questions, you can go to crackincancer.org. Let us know. Otherwise, we will see you next time.
Thank you.
Thanks, everyone. Thank you for joining us on this episode of Cracking Cancer. If you found this helpful, please like, subscribe, leave us a review, and visit crackingcancer.org for more information. Every dollar we earn goes directly to furthering the podcast and supporting vital cancer research. Because together, we can crack cancer.